neurological disorder. So again, thank you, Matt, for taking the time to speak to us, and we're thrilled to hear what you have to say on this.
Thanks so much, Roger, and really looking forward to sharing with this great group on what I think is going to be a very stimulating topic. And I'm going to try and leave a bunch of time for questions because I think with this type of group, that will be an important part of the value here. So I don't have any relevant conflicts of interest for this talk. As Roger just said, these topics of functional neurological disorder and concussion really fall in these gray zones between neurology and psychiatry, and other areas of medicine. And I want to make sure everybody understands what functional neurological disorder is. So I'm gonna bias the first bit to making sure we all are up to speed on that, because I know you all know what concussion and persistent post-concussive symptoms are. But really, my interest in this field started somewhat. I didn't really have an early inclination. I've always been interested in neurology and psychiatry, but it's really during the late years of my neurology training where I'd have these amazing neurology mentors that could diagnose like the rarest neurological condition. But when a patient with functional neurological disorder was in their care, it was actually pretty bad. And they often, would be not helping this patient get back to recovery in ways that led them down bad paths down the healthcare system and other places. And so I wrote about that when I had time in my fellowship. And I was surprised it even got accepted, but then I was even further surprised that it kind of went viral in some form, being, the articles most talked about of the year and featured in places like CNN. And it really got me very much having a large component of my practice related to this neuropsychiatric topic, which we'll focus on at the beginning of this talk. Obviously, that's paired with seeing patients who have concussion and traumatic brain injury. And so it was nice to have that overlap. And at Sunnybrook, we see a huge number of patients along the spectrum from concussions through the emerge to more severe head injuries. And so really, this is combining these two interests that kind of I have direct exposure to in my two major clinics, a concussion, traumatic brain injury clinic and a functional neurological disorder, and really seeing some of the overlap and points of intersection and how that might relate to understanding some of the patients that aren't getting better and what management strategies might be helpful for them. So, functional disorders we see across all of medicine, and this broad umbrella of, in the DSM, for example, which is like the psychiatrist kind of manual, can relate to a whole host of different things. And one of these clusters is these functional neurological disorders, and we'll define that in a second, but I just want to situate it in a broader area where a somatic symptom disorder, SSD, is like any symptom that is kind of unexplained by medical disease that is causing preoccupation and anxiety and hypervigilance. And FND is the more kind of neurology subspecialized aspect of that. And FND was previously termed conversion disorder. We'll talk a little bit about that. But it's important to highlight the great kind of discrepancy of different terminology. It's something that's held this field back, that there's also these functional somatic syndromes, which really kind of fall under the same umbrella, but have kind of their own kind of diagnostic buckets, like fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome. These are all functional disorders in medicine. And every specialty has their functional disorders, non-cardiac chest pain, et cetera. We see it all over the place. And really what it comes down to is that, the brain, which controls the body, is the same host to neurology and psychiatry. And both factors can influence these circuits, which then can lead to symptoms in a biological-based way throughout the body. And so this neurology subset of functional neurological disorder, which is the new preferred term over conversion disorder, is really when patients are presenting with neurological symptoms that are incongruent with recognized neurological disease. So it can be like seizure-like events or paralysis of one side or cognitive symptoms or dizzy symptoms. These are two new subtypes, functional cognitive disorder or PPPD, or persistent postural perceptual dizziness. I think I got that acronym wrong, but there's these new subtypes as well. And so the important thing with this field moving forward, and neurologists have gotten really interested in functional neurological disorder over the past 5 or 10 years, because they've really helped move this field from something where we just, okay, all the tests are normal, it must be kind of this exclusionary diagnosis of functional neurological disorder, to there are actually some features that are rule in positive features that we don't see in other neurological diseases. And I won't go into this, but this BMJ article did a great review on, these examination signs that show how symptoms can change with attention and inconsistencies that have validation. And so there's some really nice tables in this based on different presentations. Again, I won't go into it here. It's important, critically important, as we try and treat these patients with respect, dignity, and just like any other medical patient, because the processes that are driving these functional disorders are unconscious to them. They're involuntary. They're not putting on the show. They're not faking their symptoms. Now, there are entities where that is happening. Malingering, factitious disorder, where there is a secondary gain and they're consciously putting on the symptom. That is not what we're talking about here. And it is very rare that we would see these patients in a clinical setting. Of course, there are certain contexts where you have to keep things in the back of your mind. Is there a voluntary component here? And there can be some blurred lines. But for the most part, this is a completely involuntary process. And these people are really disabled and very frustrated, especially by doctors who might think that they're the equivalent of malingering. And so, there's different estimates, but about 10 to 30% of people who come and see a neurologist actually have functional neurological disorder. So it's actually a huge number of patients. It doesn't get talked about as much as it should, but the prevalence is quite high. And there's really a bimodal distribution. With some presentations, it's younger, around early adulthood, which overlaps a lot with some of the concussion patients we see in early adulthood. And for other presentations, it's more 50s and 60s. It is 80% women. This disorder has a long controversial history because of that high kind of preponderance towards women. In fact, its initial kind of conceptualization was this awful term of hysteria. And it's just very interesting how things have evolved and how we're trying to understand some of the neurohormonal factors and other factors that might be contributing to these distribution between genders. We've also seen, especially I'd say after the pandemic or peri-pandemic, huge rises in incidence. We don't know exactly what's driving that. Obviously, there's lots of psychological stressors, which is one component we'll talk about, but we don't know exactly what's leading to that blip recently. And so what's causing these disorders? These are brain circuit problems where networks of complex brain regions have become disrupted. And why they come disrupted, in this kind of software analogy, it's complicated, but we don't have to look too far from conventional models of medical disease where there's genetic factors and environmental factors. And when you look at the literature, the strongest risk factor that's been identified is childhood adversity. And it can range from kind of the easier to screen things like physical or sexual assault, but also things that are like parental neglect, really high expectations and stress that's put on kids from parents, inadvertently, bullying in school. All of these things can shape the brain's threat response system. And that's really what it comes down to. Is this person, whilst their brain is developing, whilst it's wiring, is that threat response system, for whatever combination of factors, getting pushed into overdrive, where it might wire itself in a bit of a different way? So we all, when our threat response system, we all have this evolutionarily preserved, hardwired threat response system to run away from the bear in the jungle or whatever. And we all get panicked. Our autonomic nervous system, our sympathetic nervous system will get pushed up to this fight or flight system. We all have some symptoms. But in people, when that system is chronically hyperactivated, that system becomes much stronger and might link to areas in the brain that are involved in a whole variety of other pain or neurological processes. And there's genetic factors. Sometimes there isn't a history of trauma or adversity. Sometimes they might just be genetically hardwired to have that kind of predisposition. And whichever way you slice it, these patients essentially have a vulnerable brain. And where I want to focus now is where the overlap happens with concussion head injuries, is that these people will have this vulnerable brain, but then they'll present with a functional syndrome. And what is triggering that? What is the actual precipitating factor? Well, it's been debunked that it's necessarily psychological factors. For a while, people thought it was psychological stressors that were really the main triggering factors, but that's totally changed to things where we're now in our larger data sets. We see that the main triggers are things that shift the brain's attention or introduce the brain to new symptoms. And especially when there's high threat value, there's models that show these issues can be particularly present, and there's neurobiological mechanisms for understanding how the brain reacts to certain stressors. But the big ones are actually injuries. That's why I'm here talking with you today, infections, and then medical treatments or new diagnoses. And these all get really amplified by when there is illness beliefs that these are, ominous or catastrophic events, or these negative health beliefs that happen in nocebo effects, which I'm going to spend a little bit of time talking about. So nocebo effects is as I described, when you actually can have these new or worsening symptoms due to negative expectations or information. And I would challenge anybody on the line today to give me something in medicine that has more evidence than nocebo effects, because in every clinical trial that's ever been done, we have this really nice data from the placebo groups of all these trials when people of informed consent are told, oh, trials through TRANSCENDENT or other places, you have to give them informed consent about side effects. So you tell them, oh, you know what, this treatment might provide some, it might lead to nausea, dizziness, headache, and other non-specific symptoms, And it turns out that patients who don't even get the medication that could cause these side effects, they get a placebo, about 30% of them will report headache or dizziness or fatigue or whatever it might be. And they're not crazy. They're really having these symptoms. And we'll talk about how that's possible. There are these brain-based mechanisms. And lately, there's been this amazing understanding of these models with this Bayesian brain predictive coding stuff that you may have heard about, that I'm going to talk to you about in a second, that really can help explain how these strong priors, so our brain is like this predictive coding model, these strong priors or beliefs basically are sometimes in disagreement with the actual sensory information that's coming into the body. And sometimes when these beliefs are strong, it actually can override the information that your body is getting. And so this is a really interesting thing. I'm going to see if it projects. I don't know if you guys have seen this before, but just take a look at this. And so there's many examples of things like this. I don't know for how many of you this kind of illusion, let's call it, work, but you're given the expectation that these plates are face down. They're actually not really face down. They're ambiguous, but if anything, they're face up with the shading. And then you're given the expectation that you're going to see a plate that's face up, and then all of them are going to flip up. And the first time I saw this, that exact sequence happened with me, and that's why I use this as an example. I appreciate it might not happen with everybody. Now I can no longer see them ever face down. They're all face up to me. But it's just this example of how when there's ambiguous sensory information, expectations given to your brain can drive your experience or your perception. And so how can these expectations, let's take the example of that clinical trial, that undisputable evidence from thousands and thousands of clinical trials, that you can still have symptoms with the expectation alone, even when you're given a sugar pill. How does that actually work? So if you have these expectations of a negative outcome, there's symptom side effects, you basically have this really strong prior belief. It's called this prior. And then what's going to happen is, okay, so you have this belief that this medication that you're taking might have the side effect of headaches. Unbeknownst to you, you're actually you have the sugar pill, but your brain will basically have to reconcile these two different things, where you have this expectation that you're going to have symptoms like headaches, but you're not you're not taking any, you're literally taking a sugar pill. So it turns a spotlight on the area that it's focusing on. And it's so normal tension or normal changes within the head get kind of amplified. And those signals literally become amplified to the brain. Again, it's like there's a microscope where any signal pops up. And essentially, it overrides this lack of sensory signals or pain signals. Didn't have a headache induced by any medication. You were given a sugar pill. And it actually, you have the perception of having pain and headache. Again, this data is, really becoming quite clear that this is possible, even if it seems like, well, that's impossible. The expectations could like drive this true event. And then what happens? Then you start having further attention driven to this headache that you now have. What's going on? Wow, this medication really is creating a headache. And then now you're not sleeping, and now you're, all those cascades that we see sometimes in post-concussive patients or otherwise can happen. And so that was obviously just broad. But when we look back at what's happened over the past 20 or so years, we see how expectations around a concussive injury has changed, where there may be nocebo effects that are activated. And so a lot of data, largely from football players, where they are having very bad outcomes of chronic traumatic encephalopathy and stuff like that, from hundreds or thousands of concussion or subconcussive blows. When that gets out in the media, these associations between, concussion and dementia and stuff like this, well, now all of a sudden you have, a person who had a single mild head injury, maybe a concussion, who associates their brain, maybe not even to their conscious, associates that with these ominous neurological scenarios. And that can create some of the cascades that I just talked about. So now, I want to blend these two lines together, focusing on concussion. And I'm not going to spend much time talking about concussion, because that's, bring the coals to Newcastle, because you guys all have extreme expertise in this field and are doing great work. We all know the symptoms that people have after a concussion, but we all know that these symptoms are non-specific, or we should know these symptoms are non-specific. And if I have a patient in my functional neurological disorders clinic that never had any head trauma, is not sleeping well, that maybe has chronic pain or some other factors, they will also describe many of these symptoms. And so there's lots of overlap here. So we have to appreciate these symptoms are not specific. And again, we all know that most people after a concussion do make a very good recovery, whether that be a few weeks, whether that be a month or two. But there is this subset of, depending on what data you use, 10 to 30%, let's say, that do have these persisting symptoms. And these are the challenging ones that, we are faced with day in, day out, of how to get them better. One really nicely done study in athletes that did kind of everything properly, where they did all these like preseason batteries, and then they followed these 2,000 high school collegiate athletes, and then a subset of them had concussion in 127, and they looked at how we can predict the outcome of these patients. And interestingly, they found that the strongest predictor of recovery time was their baseline somatization score. So this propensity to these types of non-specific symptoms, and this obviously overlaps with kind of angiosomatic process and basically how their brain is wired. And so there was a signal from, that was an old study, that there might be something about the pre-existing brain. And of course, we've seen that, mental health factors, migraine, ADHD, things like this are really clearly becoming, known risk factors for prolonged recovery. And so when you combine that with the fact that a lot of these symptoms are non-specific, this was a really nice paper in Brain, kind of getting at some of these concepts here about the fact that these symptoms are relatively non-specific. And these particular symptoms that are common after a concussion, like dizziness and cognitive dysfunction, that actually have a new kind of functional subtype that we may have missed after triggered by a concussion. These fields started to become very, very tight with regards to the patients who are having the persisting symptoms. And I'll focus on functional cognitive disorder a little bit, because we've all seen the cases of this, I guarantee you, because I would say it's a main phenotype that I can see with a patient who's 6 months, a year after a concussion, and worried that they have dementia, and describing these subjective cognitive difficulties. There's these diagnostic criteria that have been developed for functional cognitive disorder, and you'll see it a lot in the patient, where there's these really gross inconsistencies that you don't see with patients who have dementia. So like someone who has like a severe traumatic brain injury or dementia, so let's take one of my more severe traumatic brain injury patients who has like encephalomalacia of their temporal lobes and whatnot, and they're having, really major memory and other cognitive deficits. They actually have no complaints of memory issues because they're largely lack the insight because they're not remembering the times when they're not remembering. And it's their care provider that's bringing them in. It's like, holy crap, Mr. Jones, my husband is struggling with this and he's forgetting all this stuff. And then the husband looking at, what are you talking about, honey? Like, I'm not doing that. And it's like, this is much different than the patient who eloquently describes these times where they're not remembering things, right? And that they just tell you the exact sequence of events. That's showing extremely good short-term memory, actually, by being able to recount. So there's this inconsistency. And of course, they are actually having these difficulties, but it's a different type of problem. It's more the software problem. There's actually this really great checklist that was developed. This is very recent research, with pretty good sensitivity and specificity that, for example, using these items can be great for screening. And one of those is, is the patient able to detail specific examples of memory complaints? That is quite specific to a functional cognitive disorder rather than a ominous neurodegenerative disease. And check out this paper for more, but it's not perfect. They did retrospectively, but these are pretty decent sensitivity and specificity curves. So the first component of this overlap between persistent post-concussive symptoms and functional neurological disorders and broader fields is that there's, these symptom constellation overlap, right? That these symptoms are not necessarily specific to concussion. So that's the first piece. The other thing that we see, and you may have seen some case like this, is when patients who have had a concussion are now, and maybe they're more chronic follow-up stages, start having very atypical symptoms that you wouldn't normally see after a concussion, like seizure-like events. Of course, there's a marginally increased risk of any traumatic brain injury, increasing the risk of seizures. But there's features of functional seizures that we sometimes see after patients who have had head injuries. And so there's some patients that again, have a concussion and then later develop these symptoms that you're like, what? That can't be related to the concussion. And again, showing that they may have developed a functional neurological disorder as well. And so because of these two kind of convergent areas of what's going on, Noah and I felt that though there has been talk about this in the past, like there wasn't a great kind of framework or digestible piece for the kind of the masses of clinicians that really explained this complex continuum. And so, this is the main figure from this article that was just published a couple months ago, I think, where we'll describe this kind of spectrum. The first one is a patient who has a concussion, right? They'll have recovery of their symptoms, maybe over weeks to a month or two. This is your average concussion patient. There are certainly patients who have concussion, 10, 30, even more, depending on what data you cite, who have prolonged symptoms after their concussion, okay? But then we also have patients who had a concussion, like they had those kind of diagnostic criteria met for a concussion with their head injury, but that head injury may have also triggered an FND. And we'll talk about the pattern that we see a little bit more here, with some fluctuations and increased symptom burden. And then really importantly, there's this group that may have had FND triggered by their head injury and never had a concussion at all. And I think we've probably all seen these patients too, someone who like bumps their head on the cupboard and has no acute clinical signs of brain injury, but starts developing, sometimes in a bit of a delayed fashion, all of these symptoms. And so, the really problematic thing is that in broad strokes, many of these patients would get lumped together as persistent post-concussive symptoms, because we're not all that astute at some of these subtleties. I mean, this is a very complex terrain. It's not easy to separate some of these stuff, but these different curves may have very different pathophysiologies and different treatment strategies that would get them better. And so, I won't go into all these, but the factors that are favoring, this rightward shift of group 4, where there's FND and there's actually no concussion in the first place, are some of these factors, like, these very, low likely mechanisms of injuries and delayed symptoms and this more relapsing remitting course, and some of these core features of functional neurological disorders, which is this internal inconsistency. They develop these weird things that you weren't expecting that are, core to functional neurological disorders, but not typically seen after concussion. And then obviously different risk factors. And I want to spend a bit of time highlighting curve 3, which is that combined concussion and FND, because I think that is the one that we just don't understand well at all. And we think that a concussion happening at the same time FND is just like a recipe for disaster, and probably worse than other injuries, because I remember it's broad injuries that can trigger FND. And so, like, for example, I might see in my FND clinic, I literally just saw a patient, I don't think this is breaching any confidentiality, that had like electric shock. It was called electrocution, but that was a strong word, in their finger, plugging in your cord in your laptop. It was, it wasn't just like, a little, it was something, but it was not a serious injury to that arm. But of course, it was a very threatening event. And that patient has developed this persistent, prolonged, complete loss of sensation of their entire arm, clumsiness of the hand, pain in that arm. And that's a different injury that's triggering a different type of functional neurological disorder. And there can be a whole host of different injuries, but having not only injury, but a concussion, which introduces the brain to a whole host of symptoms, and having that event trigger FND at the same time, we think that this is a very bad thing that we just have been maybe not understanding well. And why we think it's a bad thing is because really, it could be two hits to some of the same brain network. So when we talked about those networks that are involved in patients with functional neurological disorders, that threat response system, that amygdala axis, et cetera, is maybe wired in a way that's put them at risk. Well, we know from basic science research of concussion and traumatic brain injury that when you have an injury like a concussion, you dysregulate that exact same kind of circuit. And so this is a mouse study, but basically mice that were, and you're not going to have any, drama with mice. These are mice, right? That were given, either sham or true TBI. They have differential responses to threat, as they do in these animal studies, and they see more detailed changes in these kind of threat response neurotransmitter systems and brain pathways. So if you had someone's brain that was already wired in a way that was maladaptive of those circuits, and then you further push that circuit in the wrong direction, well, that could be leading to bad things, and bad things being, prolonged symptoms and really difficulties coping with symptoms. And then another thing to highlight for where this, complex overlap might be born in is that everybody who has a true concussion develop those symptoms that I described before that you all see, which happen to also be non-specific somatic symptoms acutely. Everybody develops acutely. Some symptoms, some people, the symptoms go away after a week or two, but everybody develops those acutely. And those are the symptoms that we see in other neuropsychiatric disorders. So again, it's like it's clearly a state that's involving these same brain pathways. And then obviously we see similarities between the patients who are struggling in other areas of these functional disorders in medicine and concussion. There's these shared risk factors. And so, a lot of this has been somewhat abstract, but I want to bring it back into your practice. So let's say you see that patient that's further down the right end of that spectrum, a 25-year-old athlete or student who, has this fairly trivial sounding head injury, where they, bump their head on the car door or something like that. And they really don't actually have any of those acute clinical signs that we look for, amnesia or loss of consciousness or altered mental status. But, she developed these symptoms of headaches, this non-vertiginous dizziness, stuttering of speech, worsening anxiety in the days following this. Let's say at the 24 or 40-hour mark, she knew a little bit about concussion. She's reading all these blogs and websites and talking to friends, and gets to a state where she stopped school, and she's become fearful of even leaving a room because, hey, anytime she exerts herself, either cognitively or physically, it's leading to a little blip in the symptoms. And this is, weeks out now. And she's become extremely avoidant as a coping mechanism for her symptoms. And she eventually gets referred to a concussion specialist. This is like months out now, who might use strategies that are really focused on attending to those symptoms, checklists, apps, etc. And that might not be helpful. And what might be helpful is, an approach, a psychologically based, CBT-based approach, targeting that fear avoidance behavior and redirecting attention away from these symptoms and these negative beliefs, that they'll never get better, et cetera, et cetera. And so we and many others, including probably some people in script, have been trying out these types of fear avoidance, psychologically tailored strategies to benefit patients. And so just to highlight what this is based on the pain model, the chronic pain model, because that's what it's borrowed from. If you have an injury leading to pain, you can go down that nice pathway to the right where there's no fear, you confront it, you get better. Everybody has a little bit of trouble getting back walking after, a knee injury or leg injury. But there's that bad cycle, that bad loop where you start catastrophizing the symptoms, fear, avoidance, hypervigilance, etc. And so this type of patient would really benefit from some of the strategies to tackle that. And I know Transcendent is on and Roger's involved with this large, nationwide CIHR grant where we're looking at, cognitive behavioral therapy specifically for patients with persisting cognitive difficulties after concussion. And so the interesting thing that I'll just highlight is that some patients, when you suggest going down this more psychological road for their persisting symptoms, have strong antibodies to that. What are you saying? You're saying this isn't a real injury? You're saying that I could benefit from cognitive behavioral therapy to help, get back to activities? Like, there can be some pushback. And that's, understandably, sometimes they could feel dismissed and not valid, depending on how you're framing it. But there is this stigma, unfortunately, that these processes in the brain that are absolutely real are actually not real, and that they assume that it's under that umbrella of just being faking it, or anyways, it's complicated. But this conversation can sometimes not go well. And there's been many times for me who I feel like in the art of medicine that I practice, I do these conversations a lot. Sometimes, no matter what, it is read as a dismissing of their symptoms. And so I just want to balance that with this really nice patient narrative. That she was actually a patient of mine who was a director, or she was in the film industry, and she's very articulate. And she wrote about her experience on that exact column 4 or type 4 injury, where it was a very stressful period of life, and she banged her head on the fridge door and went down this bad route of prolonged symptoms, seeing these concussion specialists that didn't invoke any psychological or functional pathology, going in the wrong direction. And she really describes her pathway through that system, and eventually, with some of our help and others, getting to understand, she really nicely describes here, getting her out of those loops of fear avoidance and symptom preoccupation. and that, these are direct quotes from her in the article. It was an op-ed. And so it's just a really nice, and it came out right around that article, the time of that article. So it's just a really nice balance. And I actually sometimes give patients when I'm described, when they're clearly in that kind of FND triggered by head injury bucket, this article to give them, because it's obviously written like it's a lay piece, and it can help kind of validate experiences and shared experiences. So other than, your direct clinical practice, what are some of the other impacts of this kind of framework that we're presenting, of this overlap with concussion and FND? So we've suffered in this field of concussion so long from underdiagnosis in concussion, where injuries on the sports field especially were just not getting identified properly, and concussion was very underdiagnosed clearly in many areas. But now we're getting to a state where in some cases there might be overdiagnosis happening, and I see that sometimes through the emerge quite fair bit, where someone presents with a constellation of symptoms weeks after that are non-specific. The symptoms are non-specific, and because they had a head injury, even though it was a very trivial head injury, and didn't meet criteria for a concussion, and following the guidelines, they still get diagnosed with kind of concussion or post-concussive symptoms. So it's this balancing act. And I just want to highlight one particularly challenging situation that I deal with a lot, and you might as well, where a patient might be involved in a motor vehicle accident, and that leads to a whole bunch of different injuries and polytrauma, and maybe life-threatening injuries, or maybe like a femur fracture or something, and all the focus goes there. And then I get a call from like the rehab facility, like a month into their recovery, like St. John's Rehab, for example. Hey, we have this patient here, and it wasn't flagged that they had a head injury or concussion, but they're describing all these symptoms like, brain fog and insomnia and mood dysregulation. And did we miss a concussion? And so, it's possible that you missed a concussion because there's a high velocity injury and yada, yada. But those symptoms that their patient's having right now are very non-specific, and are symptoms you would get if you're not sleeping well, have, untreated leg pain, etc. So it gets really challenging. And we actually found, really not much guidance for what to do in these kind of situations in terms of like a validated checklist. Okay, where should we go? We need to go back to the EMS records. We need to check with the actual nature of the injury. Was there any of those, nice, signs that, based on our updated, ACRM, diagnostic criteria for mild traumatic brain injury, which is moving in the right direction, where it emphasizes that just having symptoms alone is not enough to get diagnosed with a concussion. You need to have either, evidence of some acute disturbance with the brain, whether it be amnesia, altered mental status, loss of consciousness, or some sort of documented change on initial assessment. So it's made it a bit more stringent for this more clinically probable diagnosis. It's not perfect, and it's not validated in that kind of post-acute polytrauma setting. But this diagnostic criteria, in my mind, is better than the ones we've had in the past, because it gets at, both not only the current symptoms, but also the interest. So we're trying to develop this type of tool, and actually we got a CIHR funded kind of planning grant, where I think at the next kind of CTRC, maybe in January, some of you might be asked to weigh in on what factors you think are important in identifying these patients. I think that this area that I've been talking about today has really led to some of the failed efforts to develop therapy in concussion, because even if you had a treatment that was targeting pathophysiology in concussion or lingering post-concussion, because many trials would enroll patients where maybe FND or this overlap zone is a prominent issue, that could lead to the treatment failing. And that more so on the spectrum, on the right side of the spectrum, those patients can be particularly placebo responsive for it's a whole separate talk that I give on this area, which also obviously could thwart that clinical trial. When we published that paper in the British Journal of Sports Medicine, I got a lot of interesting responses, particularly around medical legal implications of this, and kind of thankful messages. Oh, I needed something to cite on this topic because, we've been thinking it, and what do we do when the lawyer, says, hey, can you be an expert for this case where it's a fender bender and they're completely disabled now, and there's these threads of FND, and it's kind of the elephant in the room and this is obviously an added layer of complexity whenever we're seeing a case where there is active medical legal issues for a variety of reasons. But it's very interesting questions about causality, right? Like, is the injury, was the accident on the causal chain? Well, it was on the causal chain. And it was a trigger for their functional neurological disorder, or their concussion and their functional neurological disorder. And what's their prognosis? Are they going to be permanent? Well, no, they have the potential for actually a pretty full recovery, but there's a pretty good chunk of patients who do struggle for a long period. So it actually leads to a whole bunch of very interesting questions that I don't even know if there's great precedent. I've done some medical legal work in this field, and they always settle. So I don't know if there's good precedent. But obviously, there's much more research needed on this topic to better delineate these types of and have objective markers for these subtypes. This is work that Shannon and I have been working on for some time, where we're doing detailed neuropsychology and neuroimaging on PPCS patients compared to mental health controls like patients with anxiety disorder, seeing what might be specific, what might not be. I alluded to this before. This is like our biggest issue as a clinician trying to navigate this space, is this black and white thinking that my symptoms are either real and, injury and physical, or you're telling me that they're not real. This black and white thinking, and that you're actually not even, you're gaslighting by invoking the possibility that these psychological mechanisms might be, you're actually gaslighting. You're not taking me seriously. And that is actually not at all what I'm trying to do and I don't think in this field are trying to do at all, but there is this stigma, and there's this narrative that has come up recently. This is a New York Times article from a few years ago. It's tricky. It's very complicated terrain, and the patients in this terrain are slipping through the cracks. And these are just my final slides, just showing that these issues of the overlap of these functional disorders with concussion, it's not this is not the only field where this is happening. This is happening across all of medicine and neurology. I focus on neurology here, but these are relevant issues that we just weren't really taught in medical school or other allied health schools, about these roles of how these function problems can happen and how expectation can drive them. And this is a very interesting recent study that I just added to the slides yesterday because it was just published, I think yesterday, in JAMA Neurology. I'm sure we all heard about this New Brunswick mystery neurological illness that was killing people off. Well, one of my mentors, Tony Lang, just did a deep dive on this topic and reanalyzing a lot of these cases. And there's all this fear in the media of what was happening, and what the end verdict in this article is that there was no new disease. Some patients did have a neurodegenerative disease like Parkinson's, but other people actually had things like functional neurological disorder or persisting post-concussion, plus this immense fear that they were part of this cohort of this mystery toxic illness and were extremely disabled by it. And if, I just was messaging with Tony yesterday. I'm like, get ready for some hate mail, because some people are going to be coming for you now, because they're so tied to the fact that they have this mystery illness. And so these were all the articles that just came out last night. And anyways, it just is an example of how how powerful these forces can be with respect to impacting the brain circuitry. So that's it. There's 10 minutes for questions, and I'd be happy to field them. I think I should stop sharing so that I can always bring it back if needed. But thank you for your attention. I hope this was helpful.